Did you know that former U.S. President John F. Kennedy suffered from chronic gastrointestinal pain for years, likely linked to peptic ulcers? For decades, people believed that stress and spicy food were the main causes of ulcers, a myth that persisted until groundbreaking research revealed the true culprits, a bacterium and some common medications. Today, the story of peptic ulcer disease, PUD, is not only fascinating, but also essential to understand. Welcome to VOXVITA. I'm Dr. Baruch. In this feature, we'll dive deep into peptic ulcer disease, its causes, symptoms, diagnosis, treatment, and prevention. Whether you're simply curious or a healthcare professional seeking a refresher, this is for you. Here's a striking fact. Up to 10% of people will develop a peptic ulcer at some point in their lives. Globally, over 4 million new cases are diagnosed each year, resulting in nearly 300,000 deaths. In the United States alone, peptic ulcers lead to approximately 500,000 hospitalizations annually. These numbers highlight the importance of awareness and proper management. Before we explore the causes, let's take a moment to understand the anatomy involved. The stomach and duodenum are key components of the upper gastrointestinal GI tract. The stomach, a muscular organ, initiates digestion using gastric acid and enzymes like pepsin. The duodenum, the first part of the small intestine, blends the stomach's contents with bile and pancreatic secretions. These organs are protected by a mucosal barrier consisting of mucus, bicarbonate, prostaglandins, and rapidly regenerating epithelial cells. Under normal conditions, the mucosal barrier maintains a balance between aggressive gastric contents and protective factors. When this barrier is compromised, whether by infection, chemical irritation, or physical damage, acidic contents can damage the lining, resulting in inflammation, erosion, and in severe cases, bleeding or perforation. H. pylori disrupts this by producing urease, which breaks down urea into ammonia, neutralizing stomach acid locally and damaging the surrounding mucosa. The immune response to the bacterium adds further inflammation. NSAIDs, on the other hand, inhibit cyclooxygenase 1, COX1, reducing prostaglandin production, key substances that maintain mucosal blood flow and mucus production. This imbalance tips the scales in favor of acid and pepsin, leading to mucosal injury. Let's bust one of the biggest myths first. Spicy foods and stress, once blamed for nearly all ulcers, are rarely the direct cause. The real villains are Helicobacter pylori, a spiral-shaped bacterium, and long-term use of non-steroidal anti-inflammatory drugs, NSAIDs, like ibuprofen and aspirin. H. pylori was discovered by Dr. Barry Marshall and Dr. Robin Warren in 1982. A finding so revolutionary, it earned them the Nobel Prize in 2005. In fact, Marshall famously drank a culture of H. pylori to prove it causes ulcers, developing gastritis as a result. Peptic ulcer disease is more common in men, particularly duodenal ulcers, and typically appears between ages 30 and 50. Gastric ulcers are more frequent in older adults. Additional risk factors include smoking, heavy alcohol use, corticosteroids, and chronic stress, which can exacerbate symptoms or delay healing. Rarely, a condition called Zollinger-Ellison syndrome, where tumors produce excess gastrin, can cause multiple treatment-resistant ulcers. So how does an ulcer feel? The hallmark symptom is a burning or gnawing pain in the upper abdomen, often in the epigastric region. Duodenal ulcer pain usually improves with food but returns after a few hours. Gastric ulcer pain may worsen after meals. Additional symptoms include bloating, nausea, early satiety, and in severe cases, hematemesis, vomiting blood, melena, black tarry stools, or sudden, sharp abdominal pain, signs that could indicate bleeding or perforation. Unexplained weight loss or difficulty swallowing may point to a more serious problem, such as malignancy. Accurate diagnosis is crucial. The gold standard is upper gastrointestinal endoscopy, which allows direct visualization and biopsy of ulcers, especially important in gastric ulcers to exclude cancer. H. pylori can be diagnosed using a urea breath test, stool antigen test, or biopsy-based rapid urease test. Blood tests may show anemia, while stool tests can reveal occult bleeding. Newer diagnostic approaches are exploring non-invasive biomarkers for better detection of recurrent infection or high-risk lesions. Treatment focuses on the cause. For H. pylori, triple therapy includes a proton pump inhibitor, PPI, such as omeprazole, plus 2 antibiotics, typically clarithromycin and amoxicillin or metronidazole for 10 to 14 days. This regimen eradicates the infection in about 70 to 85% of cases. PPIs reduce stomach acid, promoting healing and relieving symptoms. For NSAID-related ulcers, discontinuing the offending drug is key. If NSAID use is unavoidable, say in arthritis patients, co-prescription of a PPI is strongly advised to reduce recurrence. In cases of complications such as bleeding, perforation, obstruction, or suspected malignancy, surgery may be required. Endoscopic techniques including clipping or cauterization have reduced the need for surgery in bleeding ulcers. The prognosis is excellent with early treatment. Most ulcers heal within 4 to 6 weeks, but recurrence is common if underlying causes aren't addressed. Persistent H. pylori infection is a known risk factor for gastric carcinoma and malt lymphoma.
Peptic ulcer disease is far more than occasional indigestion. It's a condition with the potential for serious complications. But with scientific breakthroughs, proper diagnosis, and lifestyle changes, it's more manageable than ever. Thank you for watching VOXVITA. For more health content grounded in science, don't forget to like, subscribe, and share. Stay informed, stay proactive, and as always, stay curious.